Very good morning, afternoon, or evening, Your Excellencies, distinguished guests, and colleagues, and friends from all around the world. It's an honor and a pleasure for me to welcome so many of you to today's event of UHC Day Dialogues. It is regarding the integration of non-communicable disease into universal health coverage in the times of COVID-19. Universal health coverage is a political choice which has been firmly rooted in the belief that the highest attainable standards of physical and mental health is a fundamental human right, and that people should have an access to the quality, essential health services without incurring financial hardships. Through the commitment made in the Sustainable
Sandus,
Development
can
Goals,
you close the door and I'll go on live.
Sustainable Development Goals and the 2019 UN High-Level Meeting on UHC, political leaders have made their choice. For these commitments to become a reality, non-communicable disease or NCDs must be included into the UHC. Unfortunately, 7 out of 10 deaths globally result from an NCD, with 85% of them occurring prematurely in low and middle income countries. Even before COVID-19 pandemic came over, research has shown that in some communities, 60% of people living with NCDs have experienced catastrophic health expenditure, and half of the people living with diabetes do not have access to the insulin they require for the survival. But COVID-19 has made things even worse for people living with NCDs. It has exposed the link between NCDs, communicable disease, and health emergencies. And it has also shown that NCDs to be in the weak link in the health system worldwide. It has exposed the damage that neglecting NCDs and underinvestment in health, prevention, and essential public health programs has done over the years in many of the countries. Yet today, we'll have an opportunity. We have an opportunity to talk with the people living with NCDs and representatives from the governments, WHO, and civil society about the solutions to these problems. Solutions as to how to ensure good quality, equitable NCD prevention and care is provided to people living with NCDs or at risk of developing NCDs. Therefore, without further ado, I have the privilege of introducing our first panelist, Dr. Samira Asma. Dr. Samira Asma is an Assistant Director General for Data, Analytics and Delivery at the World Health Organization. Dr. Asma will kindly start our discussions by providing an overview of the impact of NCDs globally, honing in on efforts to integrate NCD into UHC to date. She will also share more about the devastating impact of COVID-19 on people living with NCDs. Dr. Asma, it gives me a great pleasure to introduce you and to give you the floor. Welcome.
Thank you so very much. Good morning, good afternoon, and good evening, colleagues. First of all, on behalf of WHO, I would like to appreciate and admire the work that the NCD Alliance is doing to keep NCDs on the radar. So thank you for all the work that you are doing. And thank you for having WHO to participate. And I'll be also joined by my colleague, Bente Mikkelsen, who is spearheading and is the director for the non-communicable diseases in WHO. I would like to begin by underscoring the need that we ought to focus on non-communicable diseases. Data is very clear. A month ago, the Global Burden of Disease Estimates released their estimates and clearly highlighted that many health systems are unprepared to tackle the non-communicable diseases, which has become the leading cause of death and disability worldwide. I would also like to highlight tomorrow, WHO will be releasing the global health estimates that will demonstrate again that NCDs are going to be the drivers for devastating impact, both from diseases and deaths, all preventable. Stay tuned. The release of the estimates will be by noon tomorrow, and we will have a press conference. This is just a pre-release showing again where non-communicable diseases and injuries stack up. We will also release the leading risk factors for NCDs and other causes as well. It is also important to note that inequalities persist. And the next one I would want to highlight again is within countries, across regions. We cannot ignore the fact that the inequalities are widening, and COVID has underscored that. And if we are very sincere about realizing universal health coverage and health for all, the status of inequalities must be addressed. And you see here a very striking difference between Norway or Côte d'Ivoire, for example, from NCD perspective. The next point I would like to make is that Amina Mohammed, the Deputy Secretary General of the United Nations, recently said at the UN General Assembly that health is a docking station for SDGs, and it is. We have seen that. To not only accelerate to meet the SDGs, the world was already falling behind. And with COVID, we have derailed in many areas. And you see here how health has become a centerpiece if the world has to meet the SDGs. We are just less than 10 years away from SDGs. And every aspect of the SDGs are impacted because of COVID-19. But we have an opportunity now to reclaim the position that health will play. WHO, as you know, under the leadership of Dr. Tedros, has gone through a transformation in its 70 plus years of history. And when we established our 5-year strategy, it was built on SDGs with an aim to achieve by 2023, which is the midpoint, to reach the SDGs, which were established in 2015. So 2023 is 7.5 years, and we have 7.5 years to take an assessment. The 3 billion targets are WHO's strategy to ensure that 1 billion more people are covered by universal health coverage. 1 billion more people are better protected from health emergencies, and 1 billion more people enjoying better health and well-being. These 3 pillars are interrelated, and if we ought to promote healthy lives, not only extend lives, this is the approach that WHO has taken, to which all the countries have signed on to meet the SDGs, but to accelerate the progress. We are also taking the impact of COVID into consideration, and you will see how universal health coverage in each of these 3 billion targets are measured by each of the indices, and they are targets and indicators. If we can go to the next one, please. I will focus on the UHC index, given the UHC Day. Everyone is familiar that SDG goal 3.8.1 is about effective service coverage, and 3.8.2 is about financial protection for those that are accessing health services. The 3 billion targets that I just shared with you, the UHC component is a combined measure of service coverage and financial protection. And the SDG index addresses some non-communicable diseases, but not all. So there is a room to improve. Currently, it covers hypertension, diabetes, and tobacco prevalence. It is important that as we go forward, we ought to make sure that the essential services that addresses non-communicable diseases are in fact a part and parcel of the universal health coverage and primary health care. And we have seen with COVID that about 90% of countries have reported significant disruptions in health services. And Bente will talk more about the details, but just to give you a context, that only 17 of the 194 countries are on track to meet SDGs, and significant disruptions to NCD services has also been experienced. Day before yesterday's news from Pakistan that a number of COVID patients died because of lack of oxygen. It is really unacceptable. So this whole measurement framework underpinning WHO's strategy is to ensure that we are accountable, the way we are making progress, and how do we accelerate making progress? And if not, why now not? And how do we remove the roadblocks? Next slide, please. And we know we have the tools to address what we know what works. The pyramid that you see on the right side is the results of impact measurement framework. Aligned with SDGs, we just don't want extended lifespans, but we are all aiming towards healthy life expectancy. And the triple billion targets that I mentioned to you are each of those measured through respective indices, UHC, health emergencies, and healthier populations. And underpinning those are outcome indicators, many derived from SDGs and some through the agreed member state World Health Assembly resolutions. I'll pick 3 examples. One is tobacco control. We are all familiar with the potential that we would gain if we continue to press on to achieve the goals and targets set for tobacco control. We have FCTC, we have the Empower Technical Package. Now is the time when the countries and the global community is faced with recession. Is it not time again for the NCD community and the global community to re-emphasize that one of the very cost-effective measures to generate revenues is to increase taxes? And Philippines, as you know, and many other countries have used the revenues from tobacco and alcohol to fund universal health coverage. And this ought to become a priority. We have the means. The second example I would like us to reflect on is eliminating trans fats. It is also one of the outcome indicators. Again, it is a matter of stroke of pen for many of the policymakers to eliminate trans fats from the food supply by 2023. And that is what WHO, along with NCD Alliance and all the partners, are working towards. This is one of the only risk factor that could be eliminated within the next few years if we press on. These are the healthier population indicators that through policy measures and legislative and regulatory measures, we could make a massive influence in changing the course. The other example is how do we really strengthen the delivery of care for UHC in every country by strengthening primary health care. Blood pressure, hypertension, we know is the leading preventable cause for heart attacks and stroke. It is easy to treat. It is not expensive. We have the protocols. We know what needs to get done. But we are not there yet. And if we can scale up blood pressure management, and this could become really a leading indicator to show how effective primary health care is becoming to strengthen universal health coverage. So these are just few examples so that we can prioritize and make rapid progress. And finally, I would like to point out the next one is, as we go forward to making progress towards the 3 billion or to meet the SDGs by 2030, we ought to make sure we are making progress, we are tracking progress, and where we are not making progress, we should know how to remove the roadblocks. And that is where the delivery comes into play. Taking a vision, taking the baseline, establishing the targets, and making sure the policy and program interventions are set in place so that our decisions and our work and our time spent is all data-driven. This is the approach that WHO as an organization has taken to be accountable, to ensure that we are fulfilling our commitment to the member states. The next slide. The data underpinning these 3 billion dashboard that I mentioned to you is available, but this is the state of data availability. More than 50% of the countries are unable to report on even less than half of the health-related SDGs. So there is significant work that is cut out. Simultaneously, while we deliver policy and programmatic solutions, we ought to rapidly scale up our efforts to strengthen countries' data and health information systems. WHO, along with partners, Bloomberg Data for Health Initiative, and many other partners, launched the Score for Health Data Technical Package. Next slide, please. This represents about 90 tools and technical resources to strengthen the SCORE technical package, and each of the acronyms for SCORE outlines the ways to improve surveillance. Now we know household surveys are difficult, using mobile phone surveys to capture the information that is needed through population surveys. An invisible billion is people who don't have birth certificates or death registration, and we don't know the causes of death. Therefore, we don't know how to allocate resources. CRVS is a very important area to prioritize. Optimizing routine health information systems to track NCDs is very important. And finally, reporting and making data available publicly, and to use data to enable data to drive policy and progress is important. So this is the SCORE technical package that is now available. In January, the first global assessment of where each of the countries lie in respect to SCORE. If we don't count, it is hard to make progress. And then finally, I would like to close by summing up another idea that was introduced during the World Health Assembly, as well as last week's special session on COVID-19 at the UN General Assembly, where Dr. Tedros introduced an idea of universal health and preparedness review. It is a very interesting concept of peer-to-peer, country-led voluntary mechanism using a platform of cooperation, trust, transparency to strengthen national capacity for preparedness, universal health coverage, healthier populations, to ensure that the world will meet the SDGs. This is a space to watch. We will be serving as the Secretariat. A number of countries and stakeholders have come forward. This is a new way of multilateralism to promote solidarity, mutual trust, so that countries will work together in cooperation to identify how to improve preparedness, identify where the gaps are, and find common solutions to address those. Using the monitoring mechanisms that are already underway and the reviews that are already underway. So we are beginning this process, and we welcome everyone to join this initiative, and look forward to your questions. And thank you again for having us to be to participate in this dialogue. Over to you. Thank you.
Thank you very much, Dr. Asma. That was an excellent overview of the current situation, and you highlighted very starkly the issues and the challenges which we have if we are to move forward with the UHC. I would now ask two individuals living in two different continents with two different spectrum of health systems, one from Rwanda and the other one from Sweden. And I would like to introduce Grace Gatera, who is from Rwanda, and she's a person living with mental health condition. And I'm also going to later on introduce Katsa, who is a person who is living with diabetes. She has got diabetes, she has got an endocrine disorder, and at the same time, she has also got a brain cancer, and it is a multi-morbidity effect, which is usually commonly seen in people with NCDs. So Grace and Katsa, would you briefly introduce yourselves and share your experiences of living in countries that are working to integrate NCDs into the UHC program? And I would like to ask Grace to start. Grace, welcome.
Thank you so much. My name is Grace Gatera. I am from Kigali, Rwanda, and I work as a lived experience mental health advocate. That's not only how I work, I also identify as such. Yeah, so my story is very long. I think we would be here for years if I were to talk about it. But in short, I've been dealing with all my life with post-traumatic stress disorder, depression, and generalized anxiety disorder. And so I grew up as a refugee, so I lived in another country. And while I was there, I had all of these conditions, but I didn't know what they were, and I could not access healthcare for it because the country that I lived in, their healthcare was totally not good. As refugees, you're very poor, and you cannot even afford basic medication. So to seek for highly specialized medication for, mental health challenges or something like that was out of the question. And so I suffered until I became an adult, and I dealt with a couple of traumatic life situations. I attempted suicide twice, and I think that when I failed the second time, I was like, okay, now that I failed that, I think it's time for me to start actually working on my issues. And so I moved back to Rwanda, and it's been an incredible experience. It's very interesting to contrast two countries that are in the same sort of country situation. So it can be they could be both said that they are low to middle income countries, and they probably have the same GDP, or the country I lived in has a higher GDP than Rwanda, but Rwanda has done an incredible amount of work to make sure that conditions such as mine and NCD conditions are integrated into their universal healthcare package. And so I was able to finally get treated, get tested, get diagnosed, get treated, and I currently benefit from the same package. And so it's incredible. As someone who has worked in this area, someone who has seen this firsthand, it's incredible to see the care that they're doing. I think that their universal mental health coverage is close to 90% or 95%. I'm not very sure in the numbers. And you can see that while we still have a long way to go to actually fully integrate, NCDs, because I think all countries are failing at that. But it's incredible to see how much work has been done, how much they've listened to people with lived experience, because that's also important to get the news straight from the source, to get the news straight from people like us who know what we need and who know exactly what kind of care we deserve. And so they listen and they're trying to integrate, and they even have people in positions of power who have suffered or who have lived experience of this. Before I speak on for too long about my country, I absolutely love it, and I know that there's a lot to come. I'm going to pass on to Kesha. Thank you so much.
Thank you very much, Grace. Can I invite Katsa to narrate her experience?
Thank you so much, and thank you, Grace, for sharing your experience. So my name is Kajsa Lindberg, and I was born and raised in Sweden, but have lived in different countries as an adult. 18 years ago, when I was 13, I was diagnosed with type 1 diabetes. And I'm lucky enough to live in a country where insulin is available for free for patients like me. Otherwise, I honestly wouldn't be here today. I have a lot of friends around the world who struggle to access insulin, and insulin is a life-sustaining medicine for people with diabetes. So I've often felt that I've been given an extra life, or that I'm living a borrowed life because I haven't had access to insulin. That's allowed me to stay alive. So after having lived with type 1 diabetes for a number of years, I was diagnosed with cancer in the brain about 5 years ago, a rare and very aggressive tumor. And I moved back home to Sweden so that I could receive care, and I had to move in with my parents as well because I was too sick to live alone. I went through about 8 months of treatment, surgery, chemotherapy, and radiation, and really that feeling of having gotten an extra life really just became even stronger after being diagnosed with cancer and surviving treatment. But cancer for me and for many others is not a one-time happening that you go through and move on from. For me, the tumor and the cancer treatment has meant that I now live with 6 other NCDs in addition to my type 1 diabetes. I have chemo-induced nerve damage in my feet, radiation damage in my nose, double vision, reduced vision, eyelid paralysis, and ptosis, and a whole host of other things. Not to mention the emotional impact of living with a condition like cancer. I live a very good life. I'm very grateful for my life, but in many ways it is a battle to live with 7 NCDs and having had cancer in the background as well. It is a battle both physically and emotionally, and also practical, to be honest. Like I said, I'm lucky enough to live in a country that is quite well structured, and where I have access, but there are anything from small things like keeping track of all my dozens of medications and prescriptions, to navigating through the healthcare system, living with multiple conditions, where oftentimes I feel like I am a project manager of my own healthcare, or some kind of coordinator of health. The communication between clinics, different disciplines and clinics, it's not always that great. And a lot of times I feel like I'm repeating my whole history over and over again. It takes quite a lot of time and energy, I would say. And person-centered care is quite big in Sweden. And a lot of times I don't feel like the care I'm receiving is very person-centered. But overall, I live a good life, and I'm happy, and I'm always overcome by this. I'm often overcome by this overwhelming sense of gratefulness, not only that I've been able to survive, but that I've done so because I've had access to care, and because I've had access to quality medications, and because there is a system that takes care of me now. I know that I don't have to indebt myself or completely give up my life in order to pay for my health care. And there's a fundamental sense of security in that there is someone there that will take care of me. I might be scared of relapsing in my cancer. I might be scared that there won't be a cure for what I have, but I'm not scared that I won't be taken care of. The system in Sweden isn't perfect, but I know that I'll always be taken care of. And that to me is absolutely fundamental. And I honestly think that one of the reasons that I'm sitting here today is because we have universal healthcare coverage in Sweden. If I didn't have access to affordable healthcare and affordable medicines, I would be ruined today. I would be indebted, or I'd be dead, to be honest. So I'm incredibly grateful, despite its flaws, that the Swedish system has supported me.
Thank you very much, Grace, and thank you very much, Katja. Grace, if you were to recommend in one sentence for the countries who are planning to integrate NCD in UHC, based on your experience as a person living with NCD, what would be your recommendation in one sentence?
One sentence. It's
just one sentence.
It's past time already. Do it. That's all I'd say.
That's excellent. Okay, Katja, what would be your message? One sentence to any country wishing to integrate NCD in UHC.
It would be to see people as a whole person and not just a collection of organs, to really see people beyond their condition and realize that they are people beyond a diagnosis.
So you're talking about involvement of the multimorbidity, taking all the disease into the picture, yeah, and doing that. So that's excellent, Katja and Grace. So we have heard the other side of the story, which is for the people who are living with the NCDs. It's now my privilege here to welcome. It is my privilege to welcome Honorable Minister, Dr. Christopher Tufton from Jamaica, who is the Minister of Health and Wellness, and Dr. Emmanuel Ankara Odame, who is the Director of Policy Planning, Monitoring and Evaluation of Ghana Ministry of Health. From the political side or from the government side, we have heard from the WHO, we have heard from the people with the disease, and now we are going to hear from the policymakers of how and why it is very important that NCD gets integrated into the UHC. Minister Tufton and Dr. Ankara, why have Jamaica and Ghana seen it as an important to make every effort to improve integration of NCD prevention and care into UHC policies? And each one of you, could you give us one such policy which has made the difference? I welcome Honorable Dr. Christopher Tufton to give the first response. Welcome, sir.
Thank you very much, Mr. Chair, and let me just wish all colleagues a pleasant day, and thanks to the NCD Alliance for this very important conversation. Recognizing for us in Jamaica that there is a crisis of non-communicable diseases that demands urgent attention. We have, that is Jamaica, has made efforts to improve the prevention and care for persons who may be susceptible or who are suffering from an NCD. For the past 25 years, NCD or non-communicable diseases have been a major cause for us of mortality, morbidity, and economic burden in the Caribbean and Jamaica, accounting for some 56% of deaths annually. And in 2015, an estimated 7 out of every 10 Jamaicans died from the 4 major NCDs, which are cancers, cardiovascular disease, diabetes, and chronic lower respiratory disease. The World Health Organization Global Health Estimates of 2016 revealed too that 31% of all NCD deaths occur before the age of 70. So it is a big challenge. In order to address and regulate this, I believe a multifaceted approach is important, which we have tried to pursue, which focuses on access, prevention, partnerships, strengthening the overall healthcare system, and that of course involves universal coverage. Despite the lack of financial resources to implement effective universal coverage, however, we understand the extent to which it is needed to ensure accessible and equitable healthcare for improving our responsiveness to the needs of those affected by NCDs. And Chair, the COVID-19 pandemic has amply demonstrated this and the need to take improved access and coverage very seriously. I believe it is critical to make efforts to improve integration of NCD prevention and care into the universal health coverage policies for several other reasons. First is the issue of reducing the socioeconomic burden of NCDs. We recognize that a significant number of people who are affected by the disease are from low-income households. Affordability is therefore a challenge. And indeed, the World Bank estimates that a third of household income will be spent on NCDs, while lost in labor productivity over a 15-year period will amount to over 47.3 billion Jamaican dollars. Again, another example of being short-sighted if we do not place in sharp context the need for this level of accessibility. Direct medical costs for cardiovascular disease and diabetes, for example, also over the same period are estimated to be over $29.8 billion according to that World Bank assessment. So improving integration of NCD care and prevention into universal health coverage is, Mr. Chair, an important step towards upscaling cost-effective solutions and implementing policies that ensure that those who cannot afford to pay the associated costs have access to care without suffering financial hardships. Taking measures to improve access and coverage for those affected by NCD is also part of, for us, an international responsibility. In 2005, the World Health Assembly Resolution 58.33 committed governments to developing their health financing systems to allow all people to have access to services without suffering financial hardships. Despite the financial challenges and budgetary constraints that confront a small island developing state like Jamaica, we are committed to continuing to find innovative ways to improving coverage for NCD patients. We also, Chair, colleagues, recognize the universal coverage is important for ensuring not just access to the bare minimum, but access to effective, safe, and quality medicine. This can, of course, produce positive outcomes, but there is limited financial capacity, and this poses challenges for countries like Jamaica, other developing countries. A study in Rwanda on antihypertensive medicines, for example, found that some 20% of test formulations were of substandard quality at the time of purchase, and 70% were found to be of substandard quality after 6 months of testing in tropical climatic conditions. I believe, Chair, and I'm closing here, that the assistance of the international community is important for addressing these challenges as far as universal coverage and quality medicine or access to quality medicines are concerned. Thank you, Chair.
Thank you very much, Honorable Minister. And now I would like Dr. Nkra to give us a perspective from Ghana. Dr. Nkra, welcome.
So thank you so much. And I just want to do a short presentation. Can I show my screen, sir?
Yes, please. You are welcome.
The picture will change. The complexion of the constituency.
Okay, so we in Ghana have taken a completely broader approach in approaching universal health coverage, of which NCD is a core component. So our series of deliberations, we've agreed in Ghana that universal health coverage in Ghana means all people in Ghana having timely access to high quality health services, irrespective of the ability to pay at the point of use. So what we mean is that we are not just talking about access, but it's about timeliness. Because we are alive to the fact that in the area of emergency care, time is of the essence. Also not just looking at quality, high quality. And then in terms of irrespective of ability to pay, about what financial risk protection we put in place to ensure that people are not denied access to healthcare because they cannot pay. And our goal is to ensure increased access to quality essential healthcare and public health services. We have three key objectives that underlines our universal health coverage roadmap. And the first is to ensure increased access to better manage quality primary healthcare services. The second is to ensure universal access to interventions aimed at reducing maternal newborn. And the third is ensuring universal access to clinical and public health emergencies. And then these are the key guiding principles. We're looking at target group, financial risk protection, insurance strategic partnerships. It becomes key, especially in the context of NCDs. We are looking at the context of wellness clinics and public-private partnerships, non-state actors, development partners are key. One of the things we also realized was that our healthcare system for a very long time was modeled around infectious disease, maternal, newborn, and child health. So one of the big things that have come in our UHC roadmap is to look at the design of our current healthcare systems. Other than that, non-communicable disease cannot be taken care of. We need to look at the redesign of our primary healthcare systems to look at more non-communicable disease care being added to our primary care packages. They're being taken care of. And in that vein, looking at the HR resources we need, the logistics, the infrastructure, and all other features. And this calls for design of our systems, of our environment, and of our people. We've done some pilots in the country that shows clearly that we've been able to use cardiovascular nurses in some parts of the country. And we have seen remarkable improvements in our NCD care, especially in the area of hypertension. Also, the area of effective decentralized management is key, and domestic financing very prioritized. We are looking at UHC package of care. We are looking at the curative care, like all the clinical services, OPD, inpatient, lab and diagnosis services, preventive immunization, family planning, screening, nutrition and occupational health, promote health communication, rehabilitative care, and palliative care. These are areas we realize that the infrastructure is not very great, but these are areas that really become important in the area of non-communicable disease, and also emergency care and mental health. So these are all key areas we realize that if we are seeing primary health care, then the primary health care should provide all 7 of these. And the biggest thing we've seen in our primary health care is that it's been branded as poor care for poor people. How do we change the narrative to smart care for everyone? And that's what we are working on. So this is a UHC diagram which we are aware of. And this is how we are looking at the services. So you see a lot of the NCD things we've isolated, especially in creative care, our preventive services, and our promotive services, control of our infectious disease, healthy eating habits, air pollution, and this reduction, and rehabilitative care, physical therapy, occupational therapy, speech, end of care, which happens in a lot of our cancer services. But unfortunately, what we realized was that the infrastructure for palliative, rehabilitative, promotive, and mental is a bit suboptimal, and we need to look at the design of our current healthcare systems to bring it to the fore before NCDs can be taken care of a bit properly. So this is what I was mentioning, that we need to look at our service provision. We need to look at increased attention to RM promotive services. And then we should look at how do we enhance our service and our district level. One of the key things that we need to look at and also deploy medical officers even below district, just confidence to the communities that they are on board, and look at fiscal policy innovations that should be upskilled. So we did some initial key. We realized clearly that Our current baselines for promotive services, rehabilitative services, and paralysis are quite very low, even emergency care. And to be able to achieve universal health care and move all this into 100%, we really need to double up. And that will become an illusion. So how we intend to get there, we realize that we should start looking at health as an investment, not an expenditure. We should start looking at our health service as people-centered, not disease-centric. As one of the key questions that was asked us the last time is, we should look at the relation between the herbalist and the patient, and the doctor and the patient. And realize that health people have really not looked at first and second. And that's what the things we work off, to get the confidence of people able to come to us. And approach health from a more comprehensive level, looking at the potential of traditional alternative medicine. And last but not the least, by the whole area of IT and artificial intelligence, which are coming in strongly in the area of NCDs and all that. And to refocus government primary role from sole service provision to stewardship. And like I said in the beginning of this presentation, we really need to look at the redesign and review of our current health architecture in terms of our systems, our environment, and people, so as to be able to better be able to take care of our non-communicable disease, which is becoming a major disease burden. So these are some of the few things we are doing, recalibrating our health financing strategy to align with all this that we're talking about, finalizing our essential services package, working on our prioritized operational plan for the UHC roadmap, and then look at the major reforms we need to put in place. One of the things we are looking at is a primary healthcare provider network. So instead of having siloed primary healthcare systems, if anybody enters the provider network, it should provide all the 7 services, from preventive, curative, rehabilitative, palliative to mental health. And then even go to the point where we can even accredit said networks. And these are some of the design features we are looking at. So on this note, we want to say thank you for the opportunity. Over.
Yeah, Dr. Ankra, that was excellent, and it gave an overview. And if you note from the Honorable Minister from Jamaica, we had the question regarding the burden and how they are tackling the burden, but the challenges they are facing. And from Ghana, you have the plan and a strategy, how they want to implement the UHC with the coverage of palliation, prevention, curative services. What I notice in both the components is, where is the role of the civil society within your strategic plans? So may I ask Honorable Minister to give us in one sentence a recommendation for the countries who are planning to integrate NCDs into the UHC based on the experience you have gained in Jamaica. And then I would like, from Ghana, I would like Dr. Ankra to also give us one sentence recommendation for the countries from the policymaker side of how would you integrate the NCDs within the UHC, taking into consideration the role of the civil society. Honorable Minister, you're welcome, sir.
Thank you, Chair. In one sentence, partnerships. We have to find ways to partner with all of society, civil society playing a key role in order to change lifestyles, because it's more about prevention in the first instance than it is about cure, and partnerships are essential. So that's more than one sentence, but I'll capture it in one word: need for partnerships.
Thank you very much, Honorable Minister. Ghana's perspective?
Yeah, so one of the things we are realizing in Ghana is that the future of health is really non-health. And what do I mean by that? Clearly, we are seeing that NCDs to be taken care of will need input a lot of other sectors. There's the Ministry of Agriculture, Ministry of Youth and Sports, Ministry of Environment in the area of air pollution and other air pollution, Ministry of Interior, Energy, solar installations. So clearly, the future as we go forward is going to be more and more non-health. And the ability of health providers to work with non-health actors is going to be the future. Clearly, ICT, artificial intelligence, is going to play a big role. We are alive to the fact that we have a lot of devices that can check blood pressures on the fingers. So clearly, health education, we're taking a second look at if we are going to make a lot of progress. We need to look at our current calculation of our health professionals. We need to look broader at our tax shifting and how we can communicate. The bulk of NCD is also about prevention. It's about how health factors can work with patient actors Really, that's why we are calling for a big design area. That's so we look at our current design, we can make the progress that we want to make in NCD and in a lot of other areas that we are going to go. So that's
Okay.
what I want to say for now. Over.
Yeah. May I ask both the participants, Honorable Minister and Dr. Ankara, how has been your involvement with the different ministries as a part of when you're talking about partnership? How have you been involving the Ministry of Finance, Ministry of Economics, Ministry of Trade, especially Ministry of Finance, because that is where the budgetary allocation, finding resources for integration of the NCDs, and as you know, NCD burden is huge. How have you involved the Ministry of Finance? Just one sentence, please. Thank you.
For me, it has been a challenge for universal health insurance because of financial constraints in other areas. But generally speaking, and in particular as it relates to the COVID experience over the last year, there's far more receptiveness because it is understood that without a healthy society, economic progress is unlikely to be achieved. So there is an opportunity now.
Thank you. Dr. Ankara, please.
Yeah, so COVID has clearly taught us that health and finance needs to work together. In Ghana, we read that GDP projection that was earmarked for 6% came for 1.8 after COVID. So clearly, we work with the Ministry of Finance, and we have been working on a day-to-day basis. Recently, there's an agricultural policy coordination committee that formed with Ministry of Health, Ministry of Finance, to see how we can all have a regular platform, have a regular conversation on health relates to all other sectors, and looking at health in all policies where Ministry of Finance is playing a role, not just in financial coverage, but how we use finance as a tool to ensure health outcomes are achieved. Over.
Thank you very much. Thank you very much for that. And once again, Honorable Minister, thank you very much for taking your time, precious time, from a very busy schedule to be on this panel. Thank you very much. Finally, we have the privilege of hearing from the academic experts. We have heard from WHO, we have heard from the people with the disease, we have heard from the policymakers, and now we have the opportunity for getting the academia to give their perspective. Firstly, we will listen to a video message from Professor Modi, who is a professor of public health in University of Melbourne, Australia, and University of Malawi, who was unable to join us live because of the time differences. NCDA are publishing a report looking into integration of NCD within the UHC, which will be distributed on Monday, 14th of December. 3 key issues have been brought about by this report. 1 is the role of the civil society, 2 is the prevention, and 3 is the data, country data from NCDs from each of the individual countries. Professor Modi will emphasize the role of the first 2 of these, which is prevention and the role of the civil society within the integration of the NCDs with the UHC. And we'll play a video which has been prepared by him and which will be shown just now. So please, Grace, can we have the video?
Hi, thanks very much for allowing me to join this NCD Alliance webinar. I'm delighted to do so. I'd really like to focus on the prevention of NCDs in the context of universal healthcare. And in particular, to look at the role of the big corporations, the vectors of NCDs in the 21st century, and the role that they play in driving these pandemics, and also to look at what we might be able to do about that. I'd like to look at the situation in Australia with regards to tobacco, which I think has been a real success, but then to look at the rise of ultra-processed foods and beverages across the globe, to look at it in Australia, which we could not call a success at all, and also to look at the situation in Malawi, where I've also been working. And finally, to come back to the issue of who are the people we really do need to start to be on our side, if you like, in this battle against this huge corporate power. Perhaps I can just bring up a screen and here it is. And it's to look at tobacco control reforms in Australia and prevalence. You can see prevalence coming down nicely over 30 years. And each one of those arrows represents a major piece of policy reform. And underpinning that is a lot of evidence, a lot of research, a lot of evidence-based advocacy. It's a lot of communications along with that. It's a lot of garnering political support, garnering funding to make this actually happen, bringing other sectors in. And this has happened because of these mutually supporting strategies that have occurred. Interestingly enough, if you look at the National Tobacco Campaign, a major national campaign over a couple of years, that not only helped people change their behaviour and ring the quit line, for example, but it really helped open up policy windows. Why? Because it changed attitudes as well. So that, for example, we've been able to introduce plain packaging. Well, 20 years ago we tried that and it failed. So there these notion of mutually reinforcing strategies, I think, is really important. And just to summarise, so we've got to know what we're doing. So etiological research is incredibly important, public health surveillance and monitoring, behavioural research, program evaluation in line, and it's supporting coherent policy, legislation and regulation, which is again only going to get that if you've got good evidence-based advocacy and good communications. And it'll happen if the health professionals are completely aligned with what we're trying to do in terms of policy, and that we are making sure that other sectors are intimately involved, whether that's in this case education or trade or finance. Obviously mobilising people and communities that have lived experience with NCDs, an absolutely essential part, and making sure that we have political support and ongoing funding. I mean, in Australia, where we've garnered and got political support and bipartisan or multi-partisan support in tobacco, for example, in gun reform, in road trauma, then it's worked particularly well. But we don't yet have it in the area of prevention of obesity, and we're failing badly because we don't have the political support. And I'll come back to that a little bit later. As I mentioned before, one of the things I'm particularly concerned about is this huge rise of ultra-processed foods and ultra-processed beverages across the globe. And what this makes me really worried about is it really threatens, I think, the potential for the globe to achieve Sustainable Development Goal 3.4, which is all about reducing the prevalence of premature mortality due to NCDs by 2030. And when you look at particularly the rise in upper middle income countries and lower middle income countries, the projected rises in sales in 2024, then this is really starting to grow and grow big time. And by 2030, it'll grow even more. And we know, for example, when we look at the growth rates, that the annual growth rates in per capita ultra-processed food and beverage sales, then wow, it's really high in lower middle income and upper middle income countries. So it's almost at a standstill in high income countries. And the same goes for beverages as well, where it's a negative growth in high income countries, but lower middle income countries are really starting to build a lot. So the companies know there's this huge market there to be tapped into, and if they do that, that'll only damage health a lot and really prejudice our chances of reaching that major sustainable development goal. If I look at what's happening in Australia in this area, then we're not doing particularly well, and the reason for that is because of the huge involvement of companies and corporations, whether it's Nestle or Coca-Cola or Pepsi or any of these big supranational but hyper-local corporations, then they're intimately involved in the political process. So they're making major donations, they're lobbying constantly, so they really capture the political limelight, and they combine along with PR agencies, with advertising agencies, even with sporting organisations that they sponsor, and along with the media, then they really do make sure that it's hard to introduce effective public health legislation, but it can occur. We've seen that in other countries. In many other countries, we hope that can happen in Australia. The situation in Malawi, well, you'd be surprised that NCDs are certainly on the rise there. Consumption of sugar-sweetened beverages, even in young primary age school kids, then above 80% are actually consuming one sugar-sweetened beverage a day. Diabetes is certainly on the rise, projections between, or estimations between 3 and 6%, which is really high. So this is not just a high-income country problem, it's a global problem. And that's why, in a sense, we need a different team. We absolutely need, as we said before, people who have a lived experience of NCDs, as we've done very successfully with HIV and continue to do so, how important their experience is in explaining to the rest of the world, to policymakers, why we need to do something in this area. But we need digital strategists, marketers that actually understand the tactics and the strategies used behind the whole digital world. Business, trade and governance analysts, political strategists, investigative journalists, persuasive advocates and lawyers. We need to form a new team. We need to develop a public health playbook for NCD prevention and control. Thank you.
Thank you very much, Professor Moody, for that video. I would like to now invite one of my mentors. This is Professor Shrikant Reddy. I've known him for several years, and he has been doing a remarkable amount of work and the role of the civil society in India. Professor Reddy, would you share an example of how civil society in India has supported the government's effort towards achieving the UHC?
Thank you very much, Professor Ramaya. Let me take off initially, though, with your permission, from where Professor Rob Moody left off. It's very clear that we have to position, whether in India or elsewhere, if we have to, is the audio clear?
I can hear you well, but there are some who cannot hear you well. If you're just closer to the mic, you'll be fine.
Okay, fine. Let me proceed then. Well, in any case, as I said, if we really have to function at the national level, in terms of ensuring that the civil society works in multiple capacities to influence the movement of universal health coverage for incorporating NCDs very centrally, then we ought to look at the role of civil society in advocacy, in education of patients and population, in training of care providers, and even in the provision of care by themselves. And the civil society plays many of these roles and then manages to get a convergence between all these efforts in order to influence policy to integrate NCDs into universal health coverage. Just to give you an example from India, in terms of Pain and Palliative Care Society of India from Kerala, having mobilized through excellent community-based demonstrations, as well as training of health professionals, and through advocacy with government, not only demonstrating how community-based efforts can actually enhance the provision of palliative care, but of integrating palliative care at all the 3 levels of public sector provided care in terms of primary healthcare centers right at the front lines to hospitals in secondary care and tertiary care, so that now that the government policy in the state of Kerala very clearly involves and integrates palliative care as a part of their healthcare package. So that is where I think civil society can move many parts and many elements. But I believe it's most effective, particularly in the context of primary care-led universal health coverage. We know that absolutely primary care is the pivotal area, because even if you look at the WHO's cube for universal health coverage, the 3 dimensions, which is population coverage, service coverage, and cost coverage, it is there that primary care becomes absolutely important. Service coverage, everyone is covered at some point in time or other in life. In terms of service coverage, it is the maximum range of services that are provided, population coverage and service coverage are extensive, but it is also the most cost optimizing element of care, because by early prevention, early detection, and effective early care, we will be able to save a large number of people going into costly and technology intensive advanced care, and therefore it is the most cost optimizing. So in order to build a comprehensive, continuous, connected care at the level of primary care, and also to provide portability of care under universal health coverage, the civil society can play a great role. And even in the area of multi-sectoral engagement, which is often required in primary care, but which is usually failing because governmental departments tend to function in silos, it is the civil society which actually joins all the departmental efforts through public connectivity and also public pressure, and ensures much better synergy at the front lines and brings life to multi-sectoral coordination, which otherwise would remain notionally on paper, but never become an operational reality. And that is what we have seen even in the area of NCDs, whether it's hypertension control or diabetes control, with effective demonstration of how multi-sectoral coordination can function at the level of primary care in the community settings, even in India, in multiple places, by mobilizing people power, the NCD prevention and control have been positioned within the health system and are now entering into the universal health coverage ambit itself. And I would say very clearly that we ought to be really looking at the civil society's role, and I'm not only speaking of India, but everywhere else, as a G2G mobilization, that is governments to grassroots mobilization, or a P2P connectivity, that is from the policymaker to the people. And I would say even in terms of the so-called PPP, which is often defined as a public-private partnership, we ought to redefine it in the context of UHC as a people-partnered public health. And that is where the civil society can play a tremendous role in mobilizing all sections and ensuring that the people's voice is heard, not only in raising demands, but also in shaping policies, programs, monitoring, and ensuring accountability. And we are seeing that being reflected in different parts of India at different levels. And we hope, of course, that we will continue to succeed in positioning NCDs even more centrally in UHC as the programs develop. But a symbol of the success so far has been that in the revised national health policy, comprehensive primary health care has come in now as a result of all of this advocacy, where NCDs and mental health never featured earlier on. First time they've been included, they're put in very centrally at all levels of primary health care. Mid-level healthcare providers who are non-physician healthcare providers are now entrusted with the responsibility of point-of-care diagnostics as well as facility-based diagnostics related to NCDs and provision of care, including the provision of drugs. I think all of these have been successes of civil society advocacy and demonstration of workable models through participatory research. Thank you very much.
Thank you very much, Professor Reddy, for this comprehensive overview. What would be, in one sentence, what would be your recommendation to the countries in the developing world of how should they integrate NCD within the UHC? Just one sentence, what would be the key message from your experience you have had?
In terms of provision of services, look at the family as a unit, and you will see NCD prevention to care extended across the family at every stage of life course. And in terms of provision of care, again, take a life course approach.
Thank you very much for that excellent summarized sentence and message for all. Thank you very much. We have a few questions which I'll just bring it to the panel for just attention of the panel, because we are running short of time before I move over to the next presentation. Two important questions which are there is that how are we going to integrate, in addition to NCDs, how are we going to integrate the what we call as rare disease or hereditary disease or genetic diseases into the UHC? The second question is regarding the utilization of COVID, taking this as an opportunity of funding of the COVID program, and how would you basically use this funding within the COVID-19 response to further the goals of achieving NCD within the UHC?
You want me to take the question?
Professor Reddy, if you can, yes.
Yes. Okay, let me try and answer both the questions as briefly as possible. Firstly, in the context of rare diseases, it is very important for us to ensure that when we are planning the package of essential services, we are looking not only at burden of disease and cost effectiveness of interventions, which are very important, but also looking at the equity dimension. There are certain elements that call for care of rare diseases on equity grounds. So while we are looking at what I call horizontal equity of common services being provided to everybody under the UHC package, certain extra services or augmented resources may have to be provided in terms of vertical equity to provide additional protection for people who have gaps in health equity, including those with rare diseases who have not had care from the system. So I think if we balance both the elements of equity, we should be able to look at care for people even with rare diseases. The second element there is regarding the question of COVID-19. How do we actually position NCDs in that context? It is very simple. For one reason, it is very clear that even though COVID-19 is claiming lives because of an infectious disease causing virus, the people who are dying in the largest numbers or the people who are getting the sickest are the people who have non-communicable diseases. And that is the reason why we have to pay greater attention to non-communicable diseases, because it's not only COVID-19 virus, but even in influenza, in SARS-1, any other respiratory virus, and even in most other infectious diseases, NCDs form the major substrate for severe illness and death. And therefore, we just don't fight virus by virus. We also tackle the substrate. We try and prevent non-communicable diseases. We treat it much more effectively so that there are far less number of vulnerable people in any population to be claimed by a virus. And that is why NCDs should never be off the radar, even when we are fighting a pandemic, because we have to prepare for better results when a virus strikes again. And that is by tackling NCDs in the first place, both by prevention as well as early care.
Thank you very much, Professor Reddy. I knew you would be answering it comprehensively, and thank you very much. You have summarized it extremely well. Once again, our appreciation for your wisdom on this component of care for the NCDs within the UHC and other conditions. Just one final, if Katsa is still on the line, you participated in the global NCDA survey for NCDs, people living with NCDAs. Would you be able to summarize in one sentence what were your main findings? I know it's been a comprehensive report, but in one sentence, can you summarize what has been the key findings and what are the lessons to be learned?
Thank you, Dr. Kaushik. So the Our Views, Our Voices global consultation on COVID-19 and Building Back Better, the major findings were that the majority of the respondees had disruption or suspensions of routine services, treatment and care services. They identified that there was an increased mental health burden, that they experienced quite a lot of financial insecurity and decreased income. And what they identified as priority actions were ensuring strong and integrated primary care, in particular also to address the needs of people living with multiple NCDs, and to build health systems that are inclusive and address the needs of all people equally. And as well, of course, as would be expected, ensuring access to safe and affordable quality essential medicines and products. And what was also highlighted was the importance of involving people living with NCDs and respecting the lived experience, acknowledging people living with NCDs as experts in their own right, both in their own care and also in influencing the care of others, improving the care of others. And it was highlighted that representation of civil society and people with lived experience in any kind of discussion relating to NCDs was important, and also involving people with lived experience in the design and planning and implementation and evaluation of health programs and services.
Thank you very much, Katsa, for that excellent summary. I know it was a very comprehensive report. It's very difficult to summarize in 1 or 2 sentences, but thank you very much. And if you see from all the presentations, we have had a fascinating discussions. The buzzword is primary care, civil society, prevention, palliative care, and family unit as a unit. In addition to what we need is the involvement of the policymakers with what we call as a partnership, which is a multi-sectoral partnership. I now have a privilege to hand over this floor to Dr. Bente Mikkelsen, who is the Director of World Health Organization, NCD department. And later on, I'll hand over to Mrs. Palomino, who is a program officer with Helmsley Charitable Trust, to wrap up today's event. So Dr. Bente, you're most welcome. Most of you don't need any introduction to Dr. Bente. I think you can see the effect which has had on the NCD world since her arrival into the NCD docket. And welcome, Dr. Bente, for this presentation.
Thank you very much. Can you see my slide, Kaushik?
Yes, we can see your slide.
Yeah, I have listening. Thank you for a wonderful, truly wonderful and extremely timely webinar. This is very important. And you can see from my sort of main take-home message is that excluding prevention, screening, early diagnosis and treatment of NCD from domestic UHC benefit packages is nothing less than a tragedy. And it causes, as we knew before the pandemic, 15 million premature deaths per year. We don't know the global excess mortality, but what we have seen during COVID is like an X-ray. It's the syndemic. It is really telling us that there is no way around really doing what all of you online today has mentioned. So I'm commenting on your comments in a way that I just pulled together what is sort of governing, I would say, the support from WHO. And we must never forget that actually there is a huge commitment made by heads of state and government, and I just put them here. And I think if we only want to look at one, is really the progressively cover 1 billion additional people by 2023 with quality essential health services, and also safe, effective, affordable, essential medicine, vaccines, diagnostics, health technology, with the view of covering all people by 2030. So I am very happy that many online has shown their accountability. Thank you very, very much from Minister of Health Tufton and other people, and also for civil society really focus on accountability because we have the political commitment. Samira Asma talked about this, but I think it's worthwhile looking again. If you look at how UHC is covering different diseases, NCD is lagging behind, and we have to learn from HIV/AIDS, from maternal and child health and other communicable diseases. It was also mentioned that this is now very clear. We had a very important Lancet publication in August this year telling us that progress of UHC is actually unlikely unless we also include NCD. And Samira also mentioned the NCD countdown. Thank you very much to NCD Alliance, Lancet, and Imperial College for helping us all with this. And again, we see that we are off track. It's only 17 countries that are on track. And now we see the full effect of COVID, the dwindled progress, even despite the commitments made by heads and states of government, World Health Assembly, and for the first time in history, even one of the diseases increasing its premature mortality, namely diabetes. So thank you very much also for the statements from Grace and also Tessa, showing us mental health and diabetes and what it actually requires to be covered by the health system. So I want to, again, this is what everybody has said today, the combination of the rapid progress and then the dwindling actually to reach the targets, the chronic underinvestment, the disruption shown by the outbreak, and also the increased vulnerability for people living with NCD to get severely ill and die from COVID. It is really true that we are at a critical juncture. And I think what we have learned today is important. I show you this busy slide because we are today talking about UHC. And then sometimes it's an artificial sort of controversy between looking at different diseases and risk factors and actually looking at UHC. I think we have to get rid of that very quickly, because it is actually impossible to discuss UHC without understanding the different diseases to a deep extent. And I think, again, coming back to Tessa's very important story with her multiple NCDs and other diseases as well, just show that it is not possible to just discuss health systems per se. We need to discuss health systems to respond to. So this picture shows you where you will find us in this year and the coming years, focusing on different diseases and the different needs for the health systems to respond. And I think also you have mentioned briefly, but I think it's very important to mention the healthcare and the humanitarian emergencies. And you will see that during executive board this year, we have an annex to the NCD publication or the NCD item, setting out how we want now to focus on health and humanitarian emergencies, because I think this is a sort of a core to really look into how health systems are responding for the most vulnerable in the most critical moments. And you might know that we just did a review of all the national COVID plans, and it was really depressing. Even after Pillar 9 were included into the guidance note from WHO and from the UN Secretary General, only 6 of the countries actually mentioned anything about treatment for diabetes, for example. So there is a lot to do. And then I just wanted you to know what we do from WHO. Samira has mentioned a lot on how we work on data, and also great ideas from Dr. Tedros now to do the solidarity acts of previewing and work in peers and have peer-to-peer reviews and so on. In addition, what we do is to develop the UHC repository. So you can see that at the moment we have included many on cardiovascular, chronic respiratory diseases, cancer, diabetes, and also palliative care. Thank you very much for mentioning this. I think that needs to be mentioned much more often. And the most important thing with this is that it's not only the best buys per se, it's also taken into account what kind of medicines, what do we need from human resources, what is the system requirements, and this is the difference from what we have done before. And this, in addition to what we are doing just now across the board with all different programs, is also to develop a global public health good, how to integrate. And again, it was mentioned from several of the speakers today, the importance to at least be sure that we have a well-functioning primary healthcare system that really integrate all of these services. This is a way for us to, I would say, leapfrog and fast track some of the health system requirements for NCD. So we are also working on NCD benefit packages, and please don't look into everything, but you can see that both from Geneva level HQ and also the regions are working very, very hard on this. And I think we all know that one of the things we haven't focused enough on is really the shortfall of the human resources, which we need to be sure to do this. So how we support countries is through the governance, the health financing has been mentioned, the medicines and the technology, and as I mentioned, the health workforce and the service delivery. And we just had a strategic roundtable in 2020, how to do this. And we used countries that also are online today, namely from Ethiopia, from Ukraine, from other countries that has been working on this for a long while. And we came up with some recommendations. And of course, we need to have some more global guidance. We need to be sure that we prioritize the service listing for NCD using the compendium. And if needed, also, of course, expand the compendium. And very importantly, we have no new donors stepping up. And I think this is important news for many of you. I don't want to do this. I just want to show you this as an example. It is very interesting that since I left HQ 2 years ago, we suddenly have donors that are really the light in the tunnel. So the European Commission is now supporting us in 80 countries. It's seed money, yes it is. But anyway, I mean, it's the first time in the WHO history, at least, that we focus on integration and UHC in 80 plus countries. The second one that came was the government of Denmark really supporting us. And lastly, we now have the first NCD development strategy country, namely Norway, coming up with $122 million and supporting now 4 countries really comprehensively end to end to try to be able to implement UHC. I will now stop. I know you're probably already thinking I'm totally taking over. I don't want, but it is a kind of a summary. So we have looked into the theory of change coming out of, 20 years of engagement, political engagement and commitments for NCD, looking into what we have really discovered more painfully than ever through COVID. And I think you will be pleased to see that one of the main take-home messages is that we need to give power to the people living with NCD. We need to hear their voices. We need to have people at the table, as we saw with HIV/AIDS, to be able to co-create and find the right solutions. And we have seen lots of them actually during COVID as mitigation strategies. We need to redouble, and I'm sure it's re-triple our efforts to return to previous levels. And we have to recover from COVID hand in hand with the building back differently and finance actions for NCD. And not least and not last, but really important, to unite with partners. And we need more countries stepping up, really understanding what is development strategy for NCD. So I know that that is part of the Norwegian development minister's NCD development strategy. He wants to inspire other partners to do as they have done now and really fund these kind of sustainable changes at the level of the country. So I think all of this was mentioned. I'm sure it was more, and I have noted G2G and P2P. Thank you very much for that innovation. And we need, of course, more compelling and encouraging language to continue to inspire and to continue to work hard as we do, as we can see all of us. So thank you very much for inviting me. I'm so pleased to be here. Thank you. Thank you.
Thank you very much, Dr. Bente. And I would like to now invite Stefania to close up and wrap up the session. Welcome, Stefania.
Thank you very much, Dr. Koshek. And thank you, everyone, NCD Alliance and all the participants. This has been a really great experience and a really great set of lessons learned. So we heard the testimony of people living with NCDs, And as Dr. Mikkelsen said, there is a need for us to co-create the right solutions. We need to think about life course approach and a continuum of care. We need to think about people as whole, not just a set of different conditions and NCDs. And we also heard from policymakers about their progress and their challenges and the important role that civil society has to play in integrating NCDs within universal health coverage. Again, the people's voices should be heard in shaping policies and in promoting accountability. As Professor Reddy said, we need to promote PPPs, and PPPs understand as people partner public health. We heard about really great initiatives such as the Universal Health and Preparedness Review that Dr. Asma told us about in order to bring nations together and to promote accountability. And as Grace said, you know, it's time, it's past time already. Just do it. Just take action on NCDs. So to further this discussion, and as already has been mentioned, the Hensley Charitable Trust and the NCD Alliance are looking forward to circulating our upcoming report, Protecting Everyone, Integration of Non-Communicable Diseases into Universal Health Coverage in the Era of COVID-19, to all participants on Monday, December 14. So through this analysis of interviews with experts from Australia, Ethiopia, India, Jordan, Mexico, Philippines, Rwanda, and Sweden, the report brokers knowledge on how to integrate NCDs into UHC by showcasing tried and tested best practice country examples across economic settings and explores the roles of NCD prevention and care to enhance health security in light of COVID-19. It is sure to be a key resource for policymakers tasked with achieving UHC and a support to ensure care and financial protection to people living with NCDs globally. So thank you again to all our esteemed speakers for their time and generous insights in today's discussion. Please connect with the NCD Alliance through Twitter, with any of us through Twitter and their website to continue the discussions. We will wrap up our time together watching a video entitled The Hidden Pandemic, How COVID-19 Impacts People Living with NCDs in Cambodia. That was recently released by the Cambodia NCD Alliance. Thank you very much.
ខ្ញុំបានឈ្មោះហ៊ុនជឿនបាទយើងជាអ្នកជំនួញខាងអស់ពីមុនចាយច្រើនមែនក៏ខ្វែហើយនឹងមានកាទៀវទៀតតែអានឹងមុនស្បែកកូវីដដល់ពេលឥឡូវសេដ្ឋកិច្ចយើងអត់ដើរក្រោយកូវីដនឹងវាអត់ដើរអញ្ចឹងថវិកាខ្ញុំត្រូវបាត់មួយភាគធំណាសុខភាពយើងមានជំងឺលើសឈាមមួយស្រេចហើយលើសឈាមសុខភាពយើងខ្សោយដល់ខ្សោយយើងខ្លាចបំផុតរឿងជួបអ្នកផ្សេងហើយការដែលយើងមានអារម្មណ៍យើងគិតច្រើនយើងដេកមិនសូវបានអញ្ចឹងសុខភាពយើងទ្រុឌទ្រោមបាទទ្រុឌទ្រោមទៅតាមនឹង
Noted that the NCD was increased dramatically in the country. And what is the NCD? It's the non-communicable diseases, including hypertension, cardiovascular disease, diabetes, and cancer. And it's the main cause of death in Cambodia. The NCD itself is pandemic.
គៀននាងចាខ្ញុំជាអ្នកស្ម័គ្រចិត្តភូមិខ្ញុំឈឺជាក្តៅស្ទិញក្តៅហើយដាក់ថ្នាំអីក៏មិនបាត់ដែរចាអញ្ចឹងខ្ញុំទៅពេទ្យអាហ្នឹងគេឲ្យខ្ញុំជួសជាតិស្ករជួសទៅគេថាខ្ញុំទឹកនោមផ្អែមហើយចាដល់ពេលអញ្ចឹងទៅខ្ញុំក៏ព្យាបាលថ្នាំទិញថ្នាំហ្នឹងលេបហូបយូរទៅក៏បានធូរជំងឺខ្ញុំហ្នឹងចាក៏បានធូរពេលចូល COVID-19 ចូលមកហ្នឹងខ្ញុំក៏ខ្វះខាតថវិកាដែរព្រោះអីប្តីធ្វើសំណងអត់មានការងារធ្វើទៅណាអត់បានខ្វះថវិកាអត់មានលុយទិញថ្នាំលោកគ្រូខុសត្រូវពី3ថ្ងៃអីចឹងទៅណាព្រោះអីដោយសារអីយកលុយសំទៅទិញថ្នាំយកទិញម្ហូប
It is challenge to access the medicine before COVID. Now it even worse because they lose their income.
ទៅផ្សារអញ្ចឹងពីមុនមកខ្ញុំធ្លាប់ម្ហូបយ៉ាងឆ្ងាញ់ដែរណាចាអស់លុយច្រើនបើសិនជាមានអង្គការជួយទៅផ្គត់ផ្គង់ចាជួយផ្គត់ផ្គង់មួយចំណែកណាដូចជាថ្នាំអីអញ្ចឹងណាអាចជួយទៅអាកាត់បន្ថយខ្ញុំអ្នកជំងឺនឹងដូចមានទំនុកទុកចិត្តច្រើនខ្ញុំសួរសុខភាពនៅភូមិ5កូន4នាក់ក្រោយពីកូវីដហ្នឹងហើយនឹងជំទប់អាជំងឺហ្នឹងខ្ញុំពិបាកចិត្តដល់គ្រូទេបានថាពិបាកចិត្តហាក់ដូចថាខ្ញុំហ្នឹងវាបាក់ស្លាប់ទាំងគូនឹងហ្មងហើហោះលែងកើតហ្មងគ្រូចាទៅណាក៏មិនកើតទៅណាក៏មិនកើតគឺនៅក្នុងផ្ទះដូចជាប់ទ្រង់ដូចនៅក្នុងគុកនឹងហ្មងលោកគ្រូ
After COVID hit the world, most of my patients feel like very anxious and they worry about the COVID. In the past, Cambodia experienced significantly trauma. Now with COVID, increase the fear and anxiety even worse.